Hello and welcome to the Health and Hunger Summit, Community Partnerships to End Hunger and Improve Health. I'll be your host today, and we are so excited to have a panel and to hear your questions and your comments around how we can end hunger in our generation. I'm so grateful to have this panel of experts and people that understand both community and partnership. And today we're joined by Geeta Wadhwani, Dadit Hidayat, Jackie Brickson, JoAnna Bernklau, and Anna Stichert. And I'm going to take a moment to introduce each of them at this time. First up, Geeta Wadhwani. Geeta Wadhwani is an advocate, clinician, educator, and connector who has worked with communities and organizations for over 20 years. As a public health professional, she worked with mothers to promote healthy birth outcomes and navigated complex and fragmented social and clinical systems to coordinate care for populations with HIV. In addition, she has done a number of projects and programs around health and food. Welcome, Geeta.
Hi there.
Good to have you with us today.
Thank you. So glad to join.
Next up is Dadit Hidayat, with Kids Forward Policy and Engagement Specialist. And I will say that Geeta is with Children's Health Alliance of Wisconsin, and she's a program leader in the Wisconsin Medical Home Initiative. Dr. Hidayat is a policy and engagement specialist at Kids Forward, a research and policy advocacy nonprofit organization based in Madison, Wisconsin. Dadit has been hovering his role in between research and practical actions for over a decade. Guided by various community partners throughout his professional career, he has gone deeper into re-articulating the idea and practice of meaningful partnerships and carefully integrating his research skills in the process. Welcome, Dr. Hidayat.
Thank you very much. So pleased to be here.
Next up is Jackie Brickson with the UW Health, Clinical Nutritional Administrative Assistant. Jackie Brickson is an operations assistant for culinary services and clinical nutrition at the University of Wisconsin hospitals and clinics. She oversees the critical access food pantry serving patients at the University Hospital, Madison East Hospital, and American Family Children's Hospital. Welcome, Jackie Brickson. Next up is Jackie Bernklau, Marshfield Clinic Health Systems Community Benefits Coordinator. JoAnna is a community benefits coordinator supporting Marshfield Medical Center Hospital in Eau Claire, Wisconsin. She has been with Marshfield Clinic Health System Center for Community Health Advancement for over 6 years. She began as an AmeriCorps member supporting the Healthy Lifestyle Marshfield Area Coalition and YouthNet After School program. After completing her term of service, she began working as a health educator with the alcohol and other drug prevention programs, where she remained for 3 years. Currently, she supports the Chippewa Valley region through community health improvement efforts focused on alcohol and substance misuse prevention, behavioral health, chronic disease, and social determinants of health. Welcome, JoAnna. And last is Anna, but not least, is Anna Stichert, Security Health Plan Health Educator. Anna is a health educator at Security Health Plan in Marshfield, Wisconsin. She started employment at the organization after college in 2013. She earned a bachelor's degree from the University of Stevens Point, where she majored in interpersonal organizational communication and minored in business administration. She then obtained a master's degree in public health from Capella University. Anna currently works with employer groups to plan, implement, and evaluate wellness programs. She also provides health coaching services and workshops to assist in reducing health risks for Security Health Plan members and the community. Welcome, Anna. You know, I'm going to go in a little bit of reverse order, and I'm going to start with you, Anna. I'd like to have you tell us a little bit about yourself and how you got to this point in your career.
Well, I actually started with our organization in actually our customer service department and kind of learned from the ground up as to what we did and what we stood for. And I found my passion was in the health and wellness field. So that's why I went back to school while working in our wellness department at Security Health Plan. And since I think I've done a lot of different roles within our department, and now I've become a health educator focused on, like I said, evaluating and implementing the group side of wellness. So I'm doing some work site wellness and then also doing the member wellness side with helping people lose weight or be more active, and focusing on diabetes prevention as well.
Excellent. Thank you, JoAnna. JoAnna, tell us a little bit about your story.
Hi. So I guess I started out and found my passion for community health through a personal journey. I used to be an unhealthy individual and made a lot of lifestyle changes and determined that that's how I wanted to start my career and wanted to help others to achieve their best health possible. So I changed gears from an undergrad in nursing into community health and did a little bit of personal training. Started, like I had mentioned in my bio, started with the Healthy Lifestyles Coalition as an AmeriCorps member and found that I really loved that community health feel. And tried my hand at alcohol and other drug prevention, and it wasn't completely my passion, but still enjoyed the opportunity to make a difference in bettering the community. And when the opportunity to get more so involved in a broad spectrum of community health and wellness, I jumped at that opportunity and really have discovered that I enjoy working with community members and working to achieve a best health community in collaborating with others.
I love that. We're going to get more into that idea of something like nursing and something like community health as we talk about partnerships, but I really appreciate you bringing that up. Jackie, tell us a little bit about yourself.
Jackie, I think you're muted. Sorry.
That's okay. Can you hear me now?
Yes, thank you.
Okay. Two mute buttons. So I started in culinary services. I went to culinary school many years ago and just found that I love food and I love helping people. And so when a position opened up at University Hospital and Clinics, I kind of jumped at the chance to join. And my position now, it just kind of everything just worked out. Everything fell into place. There was an opening with the food pantry or critical access food pantry. It was just starting out when I moved to the position downtown, and it just kind of fell into my lap, and I love it. And it's something new, and we're trying to expand. So yeah, that's about me.
Dr. Hidayat, tell us about your journey and how you got to this point.
Thank you. I just realized that I'm the only one of these panelists that do not have health in the title either, or my organization. So that's my story. I do not come from the health system but I have worked with multiple different organizations that allow me to, again, to apply my research. So by training, I'm a community-based researcher. So I am a researcher. But a lot of people would see researcher as this isolated research, as an isolated world who is quite disconnected from the reality, right? So what I do in the past decade is really try to use my research and connect with multiple different organizations, and eventually the last, I think since 2014, that I started to touch on the issue of health through my work in agriculture, sustainable agriculture. And that's when, again, it's not necessarily a healthcare system, but something about community health and well-being. So from those research, then I connect with multiple different nonprofits organization, really work with mostly my organization, my partner are mostly like all volunteer organizations, which mean that they are not on any payroll. Either they are community volunteers or volunteers who have other jobs. And that makes the work that we do, at least to me, really valuable, because then we can see how they're really passionate and committed to the work that we do. So right now I'm at Kids Forward, try to do more of those. Try to connect with various community groups. And yeah, when we talk about Kids Forward, we are not just talking about the kids, but also the adults around these kids, right? How we can create an environment for kids to thrive, and therefore we also need to work with parents, with community groups, with other community-based organizations who provide the support. So I'm so pleased to be here and share how I get to touch on issues around community health and well-being.
Fantastic. Thank you for joining us. And last but not least, Geeta Wadhwani. Geeta, tell us a little bit about your story, how you got to this point, and yeah, just talk us through.
Yeah, thank you, David. So my passion for community and community health, I'd say it started long before college, but I went to nursing school and I knew I wanted to work in the community. And I didn't actually know that public health was a thing until a woman from the state public health department came and talked about public health. And I thought that's where I see myself. So my nursing career started in public health, and in the city of Milwaukee, and I spent a majority of that time working with women with HIV. And what was so interesting about that was, while I have my nursing hat on, a lot of what I did was not nursing at all. You know, I wore, many hats and learned so much from the women I worked with. I coordinated care and then some. I think what I learned from that experience and from so many of the women I worked with was HIV and a lot of the chronic illnesses that these women were dealing with were not always top priority, right? It was sometimes it was a matter of survival, of day-to-day needs, of housing, of food, of issues of safety and mental health. So I really saw the systems in a different light, and in part because the women I worked with over time, they gave me trust. They allowed me to come into their home and into their lives and into their family. And I walked hand in hand with them often through medical, housing, Social Security, mental health, jails. And so I could see how fragmented, but also how unjust some of the systems that they interacted were for them. And the inspiration came from me saying, okay, if it's these 15, 20 women I'm working with that are experiencing this, they are not isolated, that this is happening, and other people are experiencing these same challenges in the system. And so that was where I said, I'm inspired to move to larger systems. I want to help influence change. And I left the direct service to work in larger systems, both where I could learn how these large systems work and how I could influence the change. And one example of that was, what is the language, right? Each of us in our respective organizations speak a different language. So we're saying the same thing, but we can't move another system because we don't use the same language. And so I spent 5 years working for healthcare. Then I moved to a role at a Medicaid HMO. So I was given the opportunity to champion some of the implementation of the Affordable Care Act's health insurance changes, including some of the changes we saw in Wisconsin Medicaid. And then I moved to working for a Medicaid HMO, which really broadened my expanding of not only how Medicaid works, but like how things work in an HMO when they have contracts and rules that they have to follow from the state. And then I'll just add, at the same time that I was working through systems, I was working on a master's of public health, which really helped me focus on the intersection of food, of nutrition, of food insecurity and health, and helped me to think through these issues through so many different intersections, whether it was policy, programming, evaluation, racial and ethnic disparities, and many others. So that's taken me now to where I am at Children's Health Alliance, where I'm excited to share with you some of the work we're doing around food and health. And we, for those of you who aren't familiar with us, we are a statewide organization and we advocate for kids, but in a very neutral space. So we're health system agnostic, we're payer agnostic, we're all system agnostic.
Thank you, Geeta. And you have touched on so many important considerations. I'm going to jump around a little bit because we're all about this idea of partnerships and community health. And I want to start with Jackie. Jackie, can you speak into, you mentioned this critical access food pantry. Can you tell us about that, about the state of criticality around food and access to food in Dane County and in the Madison area?
Hi, yes. So I guess the critical access pantry was started because there is such a prevalence of food insecurity in Dane County and the surrounding areas. Because as you know, UW Health, it's a regional hospital, really. And there's patients, we have over 100 ED patients were screened positive for food insecurity in 1 month. And that's just the ED. That's not even counting our units, our inpatient units, the Children's Hospital and the Eastside Hospital. And bringing awareness to this is huge. Like there's so many people that don't even know that we do this. And there's so many hospitals, we've had other hospitals reach out to us wondering how to get started on this because it's so important. It's so important.
Thank you, Jackie. And we're going to come back to that, about that idea of how we spread the word around this. JoAnna, can you jump in there, because you started with your journey with personal health, and then you thought, hey, personal health nursing, I'll go to community health. Take it from Jackie to say, what's the food status about in the Chippewa Valley and what's going on? What are you seeing out there?
So we do see some higher levels of food insecurity. I think overall we pair pretty closely to what the state is at, or right around that 11 to 13%, give or take, where we're at. I think one of the biggest challenges with food insecurity and where we're located is that we've got these bigger, and when I say bigger, we don't compare to Madison and Milwaukee, but Eau Claire has got, I want to say right around 50,000 people, give or take. Sure. But we've got, a few larger cities, Chippewa Falls and Eau Claire, that have a plethora of food resources, lots of grocery stores, lots of co-ops, farmers markets, that sort of thing. But then we also have an abundance of rural communities. And once we get out into those areas, a lot of limited resources when it comes to food is available. The community that I live in is a small town that doesn't have a farmer's market, has really one grocery store, and that's it. Many of the communities, small towns, have no grocery stores, and folks are buying their food from like Quick Trips, or well, Quick Trips not a good example because they do have a lot of groceries and whatnot now. But you know, the convenience stores that it's all the prepackaged fast chips, candy bars, not a lot of access of quality nutrition in foods that way. And you know, like probably so many others too, on in any community, the cost of food is rising here as well, and that also poses a bit of a challenge for folks.
I'm so glad that you mentioned rural communities, because sometimes the urban environments and the metropolitan areas get the press, if you will. And I've worked and lived in enough rural communities to know that there's both food insecurity and instability around all social determinants in the rural communities, just as there are in the urban environments. Anna, can you tell us about the state of food in Marshfield, but I also want you to take it from the lens of the employer groups that you work with. In what's the state going on in Marshfield right now?
So in my specific position, I guess I don't deal a ton with knowing. I don't know where we're currently at in Marshfield per se. It's not technically my position. So every time we do any sort of health coaching, we always are asking those questions about those social determinants of health. Seeing, you know, are there issues with housing? Are there issues with with the food? And my role more so is how do we connect the people we're touching base with those resources? Because there's a lot of times that people are in need and they just don't know that there are, you know, options available to them. And having those providers, especially, you know, in our large center, which is our Marshfield Center, I should back up and say Security Health Plan is part of the Marshfield Clinic Health System. So JoAnna and I are connected in that sense. So JoAnna's team is actually the team that does more of the community outreach. But our team, when we're speaking with people, how are we connecting these individuals with the resources that are available? And so every member that we're talking to on the phone, we're asking those questions to see, you know, is there help that's needed? And so that we're connecting with people from different employer groups. I haven't had hunger come up, or, you know, food insecurity come up a lot when I'm talking to employer groups, but it's not necessarily that it's not an issue. Those conversations usually aren't happening at that level. It's usually those one-on-one conversations where we're finding out, oh, there is some concerns with housing, or there is those concerns with food, and then we connect them from there.
Right on. Thank you. Geeta, tell us a little bit about, Milwaukee is not a monolith, as we know, but tell us about what your take is on the food systems in Milwaukee at this time.
Wow. So let me back up, David, and say my take on that, on the food systems from what lens?
Well, I think the idea that you had spoke of the idea of the systems intersection and talking with community-based organizations, as well as advocating for children with your primary position. And I just really want to get your perspective on how you see it at the present time.
So sure. So I'll just back up a little bit and say what I've heard from Jackie and JoAnna and others about the work that your respective organizations are doing around screening and referral, screening for housing or food or employment. That type of work is happening just all across the state, and it's happening nationally. So the work we're doing in Milwaukee is really in acknowledgement and a tie to this work that's happening. And I think, David, I'm not quite sure if I'm getting at the question you're asking, but I think what I'm seeing is that there's just this tremendous energy and really good intent from health systems to acknowledge and recognize all of this other stuff that happens outside of healthcare, and the struggle with, we know a family needs food or they need SNAP or something, and how do we connect A to B? I don't know that that's happening very well anywhere, to be perfectly honest. I think everyone acknowledges it needs to happen. It's just not happening very well. And it's not it's an acknowledgement that the food system and the health system operate so very differently, right? From the number of staff as to the available resources. And I might even argue that, you know, that some of you in the food space may or may not be aware of all of this energy from the health systems to make sure that families, you know, have connection to resources. And so I think it's not just a Milwaukee disconnect. I would say it's happening all around the state and even nationally, that there's not as good of a connection across community-based health system, community-based organizations and health systems as there should or could be.
Well, and I think you said it very well, and you answered the question exceedingly well with the way that I asked the question, which was a little bit convoluted, but we know each other for a long time, so that's not surprising from me and you giving a fantastic answer. But I think that you touched on both the need and the energy, which I will get into. Dadit, I saved you for last purposely, because as a researcher and someone who has done research around disconnected organizations, I'd love to have you sum up for us what you're hearing from your colleagues here around what's happening around food and the spaces that they might be engaged with.
All right, a summary. That's a tough order. But I'll try to build on what Geeta, in the beginning of your statement, you said that you wore many hats, and I'm sure this is not just you, it's not unique for you and also for everyone. We all wear many hats. And what I observed during this whole just my career is that basically we can't really separate each hat. I mean, sometimes we have to wear them simultaneously, right? And this is the same with everyone too, like outside there with our community partners. Our challenge is mostly, like our collective challenge is to recognize what kind of power that carries within that hat. And just yesterday, I participated in a webinar around, I think about nice racism, basically. And even I came to this whole partnership, I don't bring racism in the mix, but really just how we appreciate others, how we recognize others, that even if we come to a meeting, we're sitting around the table, that doesn't mean that all of us have the same power in our voice, in our stories, right? Recognizing that is, I feel, one of the most I guess undervalued fact that we don't realize how much our voice can take a place and affect others in that conversation. So this is not just, I mean, again, like I said earlier, most of my work have been with volunteers, those nonprofit organizations who are supported by volunteers, unpaid, and some other volunteers who have other jobs. Like, their time is very valuable. So knowing that they are in my space, I found that it's so empowering that they're willing to spend that time with me, who are on payroll, who are paid to do my job, whereas everyone else is not paid to do their job. And I found that working with food insecurity, especially with food communities in food desert area, a lot of them don't get paid to just get nutritious food, right? Or to mobilize nutritious foods for their neighbors. So that's when I realized that how we can truly respect that place of power, a place of privilege, my privilege as an educated person or someone who earned degrees. I'm not saying educated. So really realize that power dynamic within that group. And when we say that we want to listen to them, and we say that we want to be respectful with them, we need to break down even deeper. What does that mean in this connection? What does that mean in this relationship? And we all know that local food movement is very much driven by communities from a place of privilege. How we can frame this in a way that it's not just about food, just like Monica said last week, what is it that we can go beyond food? What is it that we can understand better about these partners and community groups and individuals who are sharing a table or space or time with us?
I think you did a phenomenal job of really summarizing an important consideration around the recognition of power and the idea of the connection in many of the ideas of social determinants. And it made me think, Jackie, to some of the work that you do, and you did it with emergency departments. Take us through, because when someone comes to the ED, man, that's a tough time. I just supported somebody that we had to take to the ED, and not only are they not feeling good for whatever reason, but suddenly if someone's asking about their food, it's like they're not feeling good and there's issues with food. Talk us through that, and the idea of the response from other hospitals as well, because I think we're really talking about bringing people together and bringing groups together to work on an issue that's important to all of us.
Sure. So at UW Health, we have a two-question food security screening. And if a patient answers positively for either question, then that's when they screen positive for their hunger vital signs, I guess. And it's basically, we worried whether our food would run out before we had money to buy, or the food that we bought didn't last before we had money to buy. And so then from there, and there are people that won't accept the packages. They don't accept them. They turn them down. Whether for whatever reason. But from there, our dietitians just ask them. We have some medically informed food choices for them, and if they're admitted, we wait till discharge. If they aren't admitted, if they're leaving from the ED, they will take the food with them. We do have some barriers. We don't have the staff on the weekend to always accommodate this, and nursing is tightly staffed as well. They help as much as they can. Yeah, it's still a work in progress, I guess. We're still working on some of those fine points, like the weekends, or if somebody misses a package. Sometimes we've had instances where we have food packages ready and they discharge, but there's a lot of commotion at discharge, and they don't always get the food packages. So we're working on those things. As far as other hospitals, funding is a lot of what is talked about when it comes to other hospitals. They wonder how we fund the critical access food pantry. For UW Health specifically, we have Friends of UW Health is where our funding started. We do food drives, food and hygiene essential drives, and our staff donate a lot for that. And our partnership with Second Harvest Food Bank, there's a lot of no fee food items that we get. We really don't spend that much money. We have the money from Friends of UW Health, which is our charity. We have that as backup. We haven't spent it yet. So yeah.
Right on. Thank you.
I hope that answered your question.
You're doing fantastic. JoAnna, you were giving me some positive verbals with what Jackie was saying there. What's your thought about this around people who screen positive and in the ED from a health and wellness perspective, that health coaching, and then they refuse the packages? Can you speak into some of that about what was your thinking when she was talking about that?
Yeah, I could just identify with our program too, the different challenges of just working through the kinks of the program and getting things developed. So a little bit about the program that Anna and I work with. It is called a food pharmacy, and we have modeled it so that we are addressing individuals that have uncontrolled diabetes and also screen positive for food insecurity or have food needs. So we are trying to get a twofold there in addressing a chronic disease and food insecurity. We've had a hard time, I guess, engaging and keeping engagement with our participants. We the portion of our program that Anna and her team work on is that health coaching side. So folks are engaged monthly at least to do wellness coaching to try to, better their own personal habits. And then on the side of things that I more so focus on is the food procurement and distribution. So we have limited hours due to staff capacity as well. Our food pharmacy is only open one day a week. So every Thursday of the month, or every Thursday of the week for the month, we're open, and we have limited hours, but have tried to update and improve the program as needed and as we get feedback from participants. So, on the occasion, there's an individual that can't make it there because she's got a job and she doesn't get done in time. And so we leave a box of food at the appointment coordinator desk, or, check-in desk. So with other staff, so that they can pick it up. And, just already working with individuals that have barriers and limited resources, getting to the food pantry or to the food pharmacy, it can be a challenge. We've partnered with Quick Trip to provide gas vouchers for folks. We have produce vouchers and eggs, milk, and meat vouchers to try to enhance and meet folks' needs a little bit better. So we've partnered with Second Harvest Heartland and also Feed My People Food Bank to provide the food kits that they get. And so just working through to try to fit exactly what folks are looking for and also need, but then how do we keep them engaged has been a little bit of a challenge for us.
Yeah, people who are food insecure, life is not easy by any stretch of the means. And we often forget how hard it can be when you don't have the economic means to do that. Anna, can you take it from JoAnna and talk about the idea of the importance of health coaching and how important it is to give people the support they need in order to figure this out together?
Yeah, certainly. So, yeah, JoAnna gave a lot of the updates that we've made to the program just based on our conversations with the members. Where were they going for their food? They were going to Quick Trips. They were going to fast food restaurants. So that's why we kind of updated and added in those vouchers, because we were hearing from people, I get all that box stuff and canned stuff from food pantries. What I need is the healthier foods, that those fresh fruits and vegetables, those fresh eggs, those things. So we made those updates, and like JoAnna said, the hardest part is engagement. How do we get these people to understand the importance of getting their diabetes under control, and what are the risks if they do not? So I think our biggest barrier has been getting a hold of people. So we contact them by phone, and we have a lot of people who have dropped out of the program because we just can't get a hold of them. Whether that's their work schedule, our schedules don't match with theirs. We're both working at the same time during the day. So that's certainly been a barrier. But health literacy is also something that comes into play here. So they understand that they have high blood A1Cs or high blood sugars, but maybe they don't understand what they need to do to get those numbers down. They don't understand what a carbohydrate is. So in kind of just giving them the basic knowledge, and in a way that's easy to understand, what's the best way to manage their diabetes through what they're eating or their exercise. Are they following the instructions from the doctor, or should we be connecting them to a registered dietitian or a diabetes educator? So thankfully, because we're part of the health system, we can make those connections. We can look at the doctor's notes from their visits, or if they've seen a dietitian, we can look at those notes, and we just are here to enforce or reinforce those care plans that were created by their providers. So if they're not seeing their provider more than once every 6 months or once a year, having that check-in once or twice a month really can help to keep them motivated rather than leaving their appointment feeling motivated, but then that motivation kind of fizzling out over the next couple of months until they have that next appointment. So, really understanding what they can afford to. So speaking to what healthy foods are going to be affordable for them. So I'm not going to recommend they buy organic foods because they can't afford that. So what are some, affordable protein options, affordable vegetable options? What substitutions can they make that are within their budget, but also will be helping them make improvements on their health.
You gave us a lot to unpack there, from how we present ourselves to how information is received, and where people are in their journeys. And that's very individualized. And that's the idea of both encouragement and making sure that you're making that connection. Thank you for that. Dadit, I want to get you to take us in a little bit, not a different direction, but do some additive here. Because you're with Kids Forward, I want you to kind of help us connect this idea of food and food insecurity, chronic disease, and the impact on children, as I think that is an important thing as we think about the next generation. What are you hearing here, and what is your reaction to what Anna, JoAnna, and Jackie have been speaking of?
Sure, thank you. I'd like to highlight, I think, David, you mentioned earlier that life is difficult. We have no idea about how, what people have, their economic means to be, you don't say this exactly, but I'd like to add, to be food secured, right? We have no idea. And you said something about affordability too. Kids Forward is a multi-issue organization. We are a statewide policy advocacy organizations. In addition to, and I happen to focus on early childhood and education, ECE, so 0 to 5 years of age. Our argument around this is really around that, well, this kid during this early age, they process a lot of things in their brain. And research shows that if we introduce healthy food, likely when they are adult, likely they will have this healthy eating habit. Now, what I have learned also from my previous project, when we talk about food security, insecurity, and nutrition insecurity, we're talking not just about those people in food desert, because those individual community in food desert also experience all kind of social issues. And we can talk about incarceration. We can talk about literacy. We can talk about these health indicators that predominantly experienced by community of color, by poor communities. So that's when at Kids Forward we try to intersect those issues together. And my current project on Farm to ECE, which is basically an extension of Farm to School. But why Farm to ECE? Because in ECE setting, it operates very differently than school district. We don't have food coordinator, we don't have catering. So how can we help childcare providers expose this healthy food to individuals, to children? In addition, we also have Young Star QRS, Quality Reading Improvement System. It's kind of like a level of quality code of providers. We have, our research shows that of those providers located in food desert, they tend to be lower in the Young Star rating, which is 2 and 3 stars, which means that those communities who not only food insecure, but they also have less resources to provide to care for these children. So when we talk about food insecurity and food insecurity and nutrition insecurity, we really just talk about not making them live healthier, but it's just to make everything their life just a little less challenging. Oh, here it is, we have healthy food, and hopefully they don't have to pay for that, and try to leverage from food recovery organizations, so that again we can minimize the food costs, and something that they can take advantage to use not just for the food but also for the activities that they do: cutting, sharing, having a family meal, and cooking and mixing with cheese, in putting in the blender, pouring milk. So really just a little bit of thing that make their life less challenging. And we're not just talking about children, we're also talking about the teacher as well, because the teacher all most likely live in food desert areas. So these kind of healthy foods are not familiar for them. Like, how do we cook them? And then basically in a class setting, our partners, WICA of Wisconsin Early Childhood Association, our partners in Milwaukee, like they share that moment not only with kids but also with the teacher in the classroom. Try to talk about foods. Try to talk about where they are where do they come from, how do they grow, how do we grow, and how we process that so that we can eat. So really how we can interest these multiple issues at kids forward about poverty, about healthy eating, food access, and also about ways, I think we talked earlier about engagement, how ways to engage teachers and children to get to talk about healthy foods, from growing and caring, processing, and consuming. So all from A to Z basically, but having that conversation really that we are interested in doing at Kids Forward.
You know, I really like the way all of you, and Dadit, I got to say, farm to ECE, I love that just rolls off my tongue. I like the way that sounds, but, you know, people have spoken about critical access, food pantries in the ED, the food pharmacy, you know, health coaching, working with health plans. And Geeta, I'm not going to leave you off, because I think this is where I want to bring you in, because is this idea of, you said something early, really important. You said that women who are in with strategic health issues like HIV are in survival mode, and that trust is an important consideration. I think we would all consider that as well. But I want you to talk a little bit about some of your pilot work that you're doing around food and health systems and this intersection and building trust with organizations around health.
Yeah, sure. So we at the Alliance, starting this year, implemented a pilot, and it's really around working to build capacity for food systems and health systems to partner so that they can collectively address both food security and health of kids. And we started really small. We started in Milwaukee, and our role in the pilot is really the convener, the connector. So we are bringing a couple of local food pantries. We brought Feeding America Southeastern Wisconsin and 2 pediatric primary care clinics together. And we said our goal, once we recruited all of our folks, was we want you to build relationships across your systems as a pathway to work together. But we know both from the evaluation data that we gathered as a baseline for the pilot and my own experience is that health systems and food systems don't traditionally work together, and there isn't trust necessarily built up, and each respective organization doesn't know how the other operates. So it was a little bit of careful convincing and influencing to say, let's get together to start to build relationships across the systems. And what does that look like? So it's both a mix of formal and informal learning and sharing. So the learning and sharing means, what are your day-to-day operations? Who are your staff? How does your organization work with kids and families, even down to some of the process aspects of your work? How do you engage kids and families? What do you ask them when they walk into a food pantry or walk into the clinic? So that's some of the broad areas that we have structured around learning and sharing. And the formality to it is we have structured calls, and for 2021, we meet every 2 months. And that's where each organization has the opportunity to share a bit about themselves. I generally pose the questions. They're parallel questions for each of the groups, and there's a lot of sharing there. And then there's what certainly can't be planned in any part of this is the informality, which is a critical important part of building the relationships, is getting to know each other outside of calls, right? When we're on Zoom calls with 10 or 12 people, there isn't the networking or those sidebar conversations. And so the informality with the pilot is, for example, some of our clinic partners reached out to the food pantries to say, tell me more about what you do. Can we come see the pantry? And then we want to invite you in and show you how our organization works. There's been some exploratory conversations about sharing data, or even with Feeding America, we wanted to test the possibility of putting some community outreach workers in the clinic to see the effectiveness of, if we're catching families who might need food share SNAP benefits, all in one convenient spot, just as a couple examples of some of the informality. And then we purposely brought an evaluator to work with us to help guide some of our work, and then to help us move towards shared success. What does that look like for this small collaborative with a couple of different systems to work together, and then to define some shared measures of success? So we are still in a pilot phase. I would say just some of the stories I've heard from some of the partners are the perceptions they had back at the beginning of the year have changed. What they thought they understood, for example, about the food system was not what the reality was. We found some of our clinical partners are now reaching out to the food pantry partners and saying, what do you think about putting a food pantry in the clinic? So I think those are just all examples of very much how important it is to build those relationships and to understand how each of the systems work before committing to do some work together. And we do plan to continue our work in 2022 to build and go a little bit deeper, as well as wanting to test this work in a very different community. As I mentioned, we're working in Milwaukee now, but we know that the way this work would look is very different in a rural community than it is in an urban community.
Thank you for that little bit of a summation there. And I was chuckling to myself, because I think we've all been in this long enough to know that even 5 and 10 years ago, this type of collaboration really didn't exist. And as JoAnna said, we're working through the kinks. So it's that notion of working through the kinks. JoAnna, can you speak into some of these kinks and how partnerships are making something like the food pharmacy possible? Because 10 years ago, it would have been, you're at the pharmacy, you might overhear somebody needing food, and suddenly it's like, well, go to the food pantry, right? And now it's like, we want people to get it in one space. Can you speak into some of the partnerships that have been successful?
Absolutely. I think, we definitely modeled our program with Geisinger Health System's food pharmacy model in our sites. They had this beautiful, robust program where it's literally like a grocery store on site. It's open multiple days a week. They have staff completely dedicated to it. So from this big, beautiful program, we started paring it down, looking at, our community, looking at the needs, looking at the resources that are available to us. And so we started with engaging Feed My People Food Bank, who is a food bank right in Eau Claire. And the health system has been engaged with them and have good relationship with them for a number of years. So we utilized that relationship, and that was already in existence, to start the conversation, to say, hey, we would like to create something like this. And best practice is to have engagement with a food bank. So From there, because our service area that we are piloting this in is smaller population wise, having a big robust program such as Geisinger just wasn't realistic to start. So we had to think through like, well, how can we provide the food to participants in a scaled back manner? And the then director of Feed My People said, hey, I know this program with Second Harvest Heartland who's doing something similar. And they create these ready-made meal kits. So it's all shelf-stable food. We get a box of food for each participant and a lot of fruits, vegetables, some rice, beans, pastas. Everything is geared toward the dietetic need or the dietary needs that we're trying to meet with individuals having uncontrolled diabetes. So that was one hurdle we jumped through, and then was more of an internal challenge with funding and not having, I guess, enticement issues. So because of that, we can only provide a certain dollar amounts worth of a product to a potential patient. Otherwise, it's enticing someone to come to our health system. So we had to get creative, and thankfully, we do have a foundation as well. So it was essentially grant funding dollars that we were able to put towards this. So that was one piece that we were able to navigate through. And then some of the feedback that we had gotten from folks was a little bit to what I spoke to about wanting some fresh foods. You know, they essentially any food pantry that they visit, they're going to be able to get those canned fruits, veggies, pasta. How can we better meet the needs of our patients or our clients? So it's, you know, Feed My People Food Bank had a partnership or has a partnership with Quick Trip in that they provide vouchers to their participants or to their food bank participants, where it's like a coupon so that folks can get a pack of eggs or a dozen eggs, a gallon of milk, or a combination of fruits and vegetables. We were able to purchase those and provide those in addition to the food kits, because fresh food is really nice to have.
Yes.
And we wanted to be able to provide that too for our participants. And I guess lastly, it's working through, you know, how do we keep people engaged? How do we continue to meet the needs of folks, because it seems to constantly change too. So we've added on some additional education components, like how do you navigate a grocery store when you go in? You know, where do you shop? What do you look for? How do you understand a label? Things like that, and how to build a healthier plate to meet your needs.
You've given us a lot. You've given us a lot there, and I want to ask Anna to take it from you, because this idea of JoAnna's talking about the community, and you work with the employer groups. How does this partnerships matter in this space? And you also do evaluations. So talk about some of the shared measures of success that Geeta had mentioned. What are some of the things that you might be looking for?
So I guess specifically with our food pharmacy program, we're evaluating what, you know, all their biometric health targets. You know, are they losing weight? Is their blood pressure going down? Mostly is their A1C decreasing? That's what one of our main focus is, you know, watching those A1Cs to see if we're improving their results, because that is the point, is to get this uncontrolled diabetes. How do we get them into that control category? So, you know, we actually are going to be sending out blood pressure cuffs along with instructions on how to use them. We're going to be sending them scales, and going to have them using those those different things, tools, I guess, to track their progress, hopefully to motivate them to continue making changes. And we also have that partnership too with their providers, and connecting with those providers as needed if we feel like they need to be seen, or if we feel like they need to be referred to a different department because they're telling us through these connections and through these conversations that other things are going on. We have that connection then with those providers, or with those with the clinic, to make sure that they're getting the healthcare that they need in conjunction with these food boxes that we're providing. Because yes, that's super important, and that's meeting one need, but other needs that we're hoping, maybe they won't take the time to call in and make those appointments. So how can we take some of that work out for them and make it easier for them to receive the care that they need as well?
Wow, you're really giving us some really cool things. And I love that idea of tracking progress through tools and giving people the information that they need to make it easier. Jackie, I got to ask you, because you're UW Health. You don't need partnerships, right? I'm being a little bit facetious there, but even somebody like UW Health in Dane County, which is robust in resources, you need partnerships too, don't you?
We do need partnerships. This wouldn't be possible without our partnership with Second Harvest Food Bank, 100%.
Speak into that partnership, please.
So we, I'd say 75% of our food for our critical access food pantry comes from Second Harvest. Many of the items are low or no fee, and it's wonderful. We and I order the food. I do the inventory for the food pantry, and I have a little bit of I can order what they have available, so it's nice. We don't have to have this exact list, and if we would have went through all of our funding very fast if it weren't for Second Harvest. It's great. They're super accommodating. There's been times where we had a very busy week in the food pantry, and I typically only get an order once a week from Second Harvest, and I was already past the deadline, and they accommodate. I emailed our representative, and she took care of it for me, and she had it there on the delivery day. We wouldn't be able to do it without them, for sure.
And that certainly is, it's to say that we build trust through relationships. And thank you for calling out your partner in a positive light. Yeah. Geeta, you are in the midst of Partnership Central. You are partnerships everywhere. You're crawling with partnerships. Speaking of some of your partnerships, and what has it meant for the health of your community?
Oh, well, that's a big question. I think, what I've learned over the years working across just a variety of systems, we can't move our work forward without our partners, without the trust, without the relationships, which ultimately, right, will influence the health of the community, I think, in the longer term. The work that I'm focused on, I know others are in direct contact with individuals, with families, with kids. We don't work directly with kids and families. So our influence on the health of kids is that we really want to influence the systems that we work with to change their practices, to do different, to think differently, so that at the end of the day, our systems, and we all work in very complex, right, hard to navigate systems, that the systems are easier for families, easier in their eyes. If easier means accessible, convenient, proximal, or in the case of our work around food security and health, we really want, when families are connected, whether it's from the food system into the clinic or the clinic to the food system, we want that connection from a family's perspective to feel comfortable, to feel warm, to know that, I trust this pantry and this person is telling me I can go to X clinic or X system and they'll take care of me. So that's how we want health to sort of show up, is that we as individuals who work in the systems make the systems easier, better for families, then families feel less of a burden or a stress in navigating all the complexity.
Thank you. I really appreciate that. Dadit, I want you to take it from Geeta, because I'm going to give it to you this way. She spoke of trust and relationship, and you spoke of power before and power imbalance. Can you speak into this idea of partnerships, trust and relationship, and culture? I think that we don't want to lose sight that Wisconsin is not a monolith of culture. And how do we navigate these partnerships with an eye to that around culture and health?
Sure. So recently, I had a conversation with a family provider in Milwaukee who came from Mexico. She's been a very strong advocate, so without a doubt. So, but one thing that I learned from her is that as much as us, like now government and all these big groups, try to be as inclusive as possible, as participatory as possible, my conversation with her led me to believe that we can't really just assume that people would be very excited about that. From Mexico, she gives an example that it's acceptable when government asks people to do things. It's uncommon for government to reach out to the community to be inclusive. So when we try to engage in my work, Latina family provider, for example, that you should not be surprised if they are shy and not as outspoken. And it's because it's the kind of democracy that they know. They came as an adult coming here. And when government or us kids who try to approach them and try to really we try to listen, we'd like to listen to your story, we'd like to listen to your voice, but it's not easy to just really get them speak about their experience. And that's the trust, right? That's the trust and relationship. We can't just invite them in a space where we expect that they would tell a story that would help me get more donor or get policy on the book. It takes a lot of time. It takes days. Relationship does not happen just because we're sitting around the same table or through email or phone call. We really have to, at least from my own experience, I have to present myself in the most genuine way where it doesn't have to be my project. It doesn't always have to be a policy. I show up in a community space just because I want to be there and really sharing meal time with them and sharing some conversation that has nothing to do with my project. That for some is inefficient, yes. But I have found lately that a lot of people talk about how this inclusive process DEI as a necessity, that we have to do it, but we are not at a level where we're spending those time, understanding that spending that kind of time, like in community meal, is valuable. So that is how we are still struggling, because when I think I heard before, like community engagement is still essential and yet difficult. Yes, it is difficult, but partly because making that connection with people coming from different culture just requires time. And the language barrier, definitely one thing, right? But there are a lot of barriers that we have to deal with. And again, we will not fix it by having like inviting them from email. They don't even have, maybe they don't read emails. Some of these people who we want to hear their story, they don't even respond by email, not because they don't want to respond by email, because email is not their means of communication, right?
Yeah,
So
go ahead, keep going.
Yeah, it's just how we can understand the diversity of how people navigate their lives, communication and just exchanging information. If we can understand that and we could go that far, then we will know how to effectively engage them and build that trust that we need.
Absolutely. And it's walking with the people. And I was going to make a joke, and I have 25,000 unread emails, so I don't read email either. And so so there are many of us that are like that, but it means saying yes to possibilities. And I want to ask you this question. I want to ask you all this question, or some version of it. And for some reason, I'm going to start with you, Anna. You know, your organization said yes. We want this. We want to build our world to make it easier for the people who have struggled the most. How has your organization said yes to building equity in the state of Wisconsin? Anna, I'm just going to start with you. How has Marshfield done this in your eyes?
Yeah, so I mean, our mission statement, right off the bat, we're trying to help, our community members find accessible, affordable, and compassionate healthcare. So, we that is one of our top, yeah, that is our mission, is to help these individuals to get the care that they need at a price that they can afford. So our organization, we do a lot of grants and a lot of community giving to help the community to provide these resources, especially in these rural areas where there may not be as many opportunities as the larger cities may have. So we provide that funding to help organizations, and JoAnna would probably have a lot better ideas to that process. And then just making sure we're connecting those people with those resources. That's my main role, is that connection piece, getting, finding the people who have those food insecurities and connecting them to the people who can help.
Great. JoAnna, take it, because your colleague called you out on it. And so take it from her
Sorry,
around this
JoAnna.
idea I know you guys are good friends, so it's like, it's in a good way, about how your organization has said yes to, working out the kinks, as you like to say.
Yeah, I think part of it is we, as a whole, our organization, it has really prided itself in continuing to provide healthcare to those rural communities. This is far beyond the food pharmacy model, but in a day and age where there's so many critical access hospitals, the rural hospitals, clinics that are just not able to survive and are having to close their doors, we continue to try to open our doors and build new hospitals to meet the needs of those rural communities. I mean, those are definitely the people that we seek to serve and provide care for. And it's not easy. It's not the easy group of individuals to serve. We've had to really think what is going to be the best for the population in the communities that we are in, and not necessarily how we're going to make the most money, because that's really not in it. Like a factor in it is we're meeting the needs of those that others have had to turn away from. And I think that's something that I'm rather proud of our organization for continuing to do, even though it's not easy, but this work isn't easy. Looking at the food pharmacy model or pilot program in particular, we've continued to say, well, what do these individuals need? Like, we take for granted the simple things as having knives and cutting boards and measuring cups. And when you're asking someone to prepare food that is healthy and not go to a fast food restaurant, but they don't have the tools to cook it, that's a barrier, and they can't eat that way. So that's one other thing that we've worked through is, don't have knives? All right, here you go. Here's a set of knives. Here's cutting boards. Here's the tools that you need to prepare your own food. So it might not be a big, flashy health equity service that we're providing through this program, but it's meeting people where they're at, and just trying to help in those little itty bitty ways that could make a difference to them.
Thank you for that. And the often we go, if those people would only eat healthy, and I say that with a bit of facetiousness, because without realizing what the needs are, and as Dadit mentioned already, the idea of walking with the people is important. And I love this question by Catherine Klinger, who asked about organizations and industry that supports food pantries in part, and they don't pay their employees a living wage. This is one of those and moments. Oh yeah, and we should be focusing on a living wage and making sure that apartments have stoves and refrigerators and that the electricity is turned on year round. Geeta, I wanted you to take this because I want you to take this idea of equity in an and situation. How do we help organizations realize that it's not only supporting food pantries, but it's supporting employees for a living wage and living in safe and stable housing and have utilities, which really most of us with privilege take for granted?
You know, those are big questions, David, and certainly questions that we're still asking and trying to address now. And I can tell you how I'm trying to address some of those questions. We know, right, issues of equity are within, or inequity, right, are just within all of our systems and all of our structures, right? We've all lived with them for the good or the bad. And I think one of several ways that I'm trying to address it more at the system level, David. So I don't know that I can speak directly to stoves for individuals, but some of the work that I'm trying to do with, say, the health systems is really to shine the light on this idea, Dadit, that you talked about, the power inequities. The elephant in the room is when I think about working with community-based organizations and health systems, the power imbalance is very real in terms of resources and number of staff and dollars, et cetera, et cetera. And so the way I've addressed that particular issue of inequity is to have some direct conversations, in part with the clinical partners, to say, this is the reality of what happens when you look at the resources and the wealth when you're within your system, and then think about how community organizations are funded. Community organizations don't have just the sheer number of staff to show up, right? Because they might have staff members, but one person wears 15 different hats. So that's just an example of me saying, in part right now, before even getting to the what to do, I find it's building a lot of awareness to say, did you know that this is a reality, and trying to bring some real life example or even people to show, right, that these are the inequities and the practices that get in the way, frankly, of partnership if we don't address them front and center.
You know, I'm glad you brought that up because it made me think of that. I've been working in food insecurity for the better part of a dozen years. And I think we're better about shining the light on the inequities and building those partnerships. I think we can continue to do better around that. But I think that it's a work in progress. You know, those of us that are here and on this webinar today are exceedingly impatient, and we want it done today. But, you know, we're working across generations. But thank you for calling that out. Jackie, I'm going to bring you in because I want you to speak to say, how is UW saying yes to equity and to health equity in this realm? And what is the organization's thought process around that from your perspective?
From my perspective, I think that UW Health they do a lot. But I think overall the conversation is changing with that, and people are speaking out about the inequity with it. And you need to pay your employees a livable wage, and I think I feel like that's on the horizon. I don't know for everywhere, not just UW Health. Like I feel like things have shifted, and it's a conversation that's ongoing. Everybody's talking now, so I hope that UW Health and a lot of companies will start doing that.
You know, it's we got to lead by example, and I know that my organization MCW has raised all of its employees to the minimum of $15 per hour. All right, and so that is an important consideration. And as we go forward, we need to talk to our vendors about that, about making sure that they pay their employees $15 an hour, and to hold each other accountable in this. Dadit, what do you think about this when you hear about this idea of equity and this talk of equity? What's the reasoning behind it? How are we moving in this direction? And are we doing enough to build a more equitable world?
So we can do more, definitely. That's my short answer. But let me build, I think Geeta said something about direct conversation. What we collectively don't realize is that direct conversation will lead to conflicts. And there is no transformation without conflict. I think there's a tendency that people avoid conflicts because we're just going to have a happy life. We're going to be friendly, working this through together. Collaboration, collaborator, or impactful collaboration will not take place like in a happy, fun way. It will involve conflicts. The problem with that is that we of us are not prepared dealing with conflicts, and that we are not trained to do that. There is no training in higher education, regardless of your degree. There is no classroom teaching us about conflict resolution, right? But I feel that's the key. One of the keys in working in racial equity, inclusion, or participatory process, however you call it, that we tend to avoid that conflict because we're not prepared. We tend to avoid that, and we don't want to. I mean, as like we don't want to grow. So how we allow ourselves to go through that conflicts, knowing that it's not going to affect our trust, knowing that we are still going to be friends, but really navigating that in a way that we have this common goal. We want this project to work. We want this vision to realize. But I have found that dealing with that conflicts is one of the key barriers that we have to deal with. And how do we get better at that? That's the big questions.
I love the way you said that, and that was noteworthy to me. And for those taking notes, that idea of no transformation without conflict, I think that is a powerful statement. And to have a relationship built upon trust and not battering whether we don't have to agree. And I think that there's a great deal of uncertainty that goes with the notion of how we solve these issues as we go forward. I'm going to ask each of you, I'm going to see if we have, I'd love any questions from the audience, if you have anything that you want to say from this outstanding panelist. But I'm going to ask you, each of you to answer this question for us as we go forward 5 and 10 years out. What do you envision with the work you're doing? How do we build synergy and multiply our efforts so that it's even at a greater level in a decade from now? I'm going to start with you, Jackie. What are your thoughts around how we can build synergy for the next generation?
I believe we just need to keep talking about it. We need to get it out there. We're sharing what we're doing with other hospitals, and I guess our clinics are opening up pantries, and we're trying. We have interns working on things, and I think we just need to keep the conversation going. I think that keep talking about it, keep offering these things, finding new ways to make things work. Like we had some space issues at first. We were working out of a closet, but we made it work. Like I turned my office into extra storage. We had space in the kitchens for cold food and everything, and we just keep innovating. We keep doing whatever works. We just keep trying, I guess.
I'm going to borrow that one. I will work out of a closet, but I'm not staying in a closet. I'll tell you that, Jackie.
Exactly.
And if we're there in a decade, then we're going to say, what the heck was wrong with us? JoAnna, take us a decade out. What is your thoughts on how we keep this movement moving forward?
I'd really echo what Jackie said. Continue the conversation and learn from one another. Continue to just, take what one organization is doing, share it, continue to build and grow from it, and enhance and put your own spin on it. And continue to pull in the voice of others too. So, the individuals that are in it that have that are impacted, basically the ones that we're serving are the ones that we need to continue to hear the voices from too.
I love when you said, I'm going to take and double down on what Jackie said. Anna, take it from JoAnna. What would you like to see in a decade to keep this work moving forward? Anna, you take it. I'll come back to her. Geeta.
Sorry, I'm having a little bit of a connection issue.
I got you now. Take it from JoAnna, and what would you like to see in a decade from now?
Well, I couldn't hear JoAnna, so I'll just guess. But I can say a couple years ago, we weren't asking, even I guess 2 years ago, we weren't asking those questions on the social determinants of health when we talk to each member. So I feel like we've already come a long way. So I think continuing to build on that. So right now, we're just referring out to resources. So eventually, maybe we'll provide some of those resources. We'll be that first connection, since we have that relationship with them, instead of passing them off. Maybe that would be an option. With our food pharmacy program, maybe that would expand to different areas. There's a lot of things up in the air as to what the next steps are for that program. So those would be kind of the couple of areas that I think, we may improve on, and maybe more provider support, making sure that those providers are asking every patient, those SDOH questions too, and providing those resources, because people really trust their doctors, and having that come right from them to provide those resources, I think that would be a step in the right direction as well.
Fantastic. JoAnna talked about building the conversation and growing and innovating is what I heard JoAnna saying. Even if she didn't say it, that's how I wrote it down. But thank you for that. Geeta, take it from Anna. And what are you seeing a decade out from now?
When I hear that question, David, I think about sustainability, and not just from the lens of our pilot work, but where do we go in 5 or 10 years? And I think about it in 4 buckets. I think about it from a policy lens. I think about it from a funding lens. I think about it from a capacity, and not just staff, but I think there's many, we could define capacity in many different ways. And then I think about it from the information sharing lens. And I think that too is broad about how we communicate, how we talk about what we're doing. And so I see those efforts in the short term helping to kind of support where we could be in the future. I think we're going to need some policy, right, and some funding and some capacity to continue to build and enhance what we do. I think in the short term, and this was said earlier, we really need to demonstrate that what we're doing and the critical partnerships and the work that we do as partners needs to continue, and why, right? We need to have different narratives or different stories, and then uplift our partners, all of our partners, to share those stories. I think we all, right, look to news and information in different outlets. So we need to make sure that the news and information is coming from just a variety of different avenues. And I also think about demonstrating it from, like, we need to be our own model. We need to walk the walk and not just talk the talk. And I think one of the models I think about is the co-creation, that we, from our pilot lens, we don't want to create a roadmap and say this is what everyone needs to do, but we need to co-create together. And then I think also to get us to that long term is we need to continue to influence, right? And it's really tied and connected to the communication and information sharing. But I think those are a lot of pieces we need to get to a new way of working together, right? Where it's not a new idea. Some of these cross-sector collaborations, right? For some of us, it's not new, but for many, it is quite new. And I'd love to see it where it's not new. It's just what we all do.
Love it. Dadit, take it.
Yeah. It's not something that is new, but it's something that we have been doing, right? Sometimes as a researcher, I failed. I'm not going to say we. I failed to recognize what current knowledge already exists, right? So my vision 5-10 years from now is that, well, before that, of course, in the process, we also have to educate our donor. Kidsword is a nonprofit organization, just like Geeta said. We also need to see on the funding point of view, like we educate our donor too, give us more flexibility. But what kind of flexibility? So 5 to 10 years, the kind of flexibility that we would like to see is that how we can help groups or people realize their unique role, so that when it comes to collaboration, we all understand that each of us has that complementary role to some other. We don't have to be able to do everything as an organization. We don't want to be able to do everything. We want partners, and that means we want to recognize that other groups, other people, other community-based organizations will help us to do something, and we will offer something that they do not have. So I have found that this idea of understanding that we are not competitor, we are collaborator, and it's okay that I'm not going to be able to do that because someone else will do that. And the challenge is how we can make that connect. So that's the kind of flexibility that we keep asking to our donors, that allow us to do all those things. We will not report you how many families receive a veggie box or how many families show up in an event. We're not going to report you to do that. That's like a self-satisfactory survey evaluation that, yeah, we want to make our donor happy, but we want to see the reality. We want to present you with a reality that we need to work together and better. And in doing so, we need to understand what we are good at the same time, what we are not as good at, so that we know that someone else can do better than us.
I love that, and I really think that that's a perfect place to end. I want to reach out to say a shout out to Cecilia for her response on training in positive conflict. I would recommend Patrick Lencioni's book, The 5 Dysfunctions of Every Team, is a good one to talk about the idea of trust building and conflict. I would have loved to clear my schedule for the next 3 hours, but I know that everybody has other things to do. I want to thank Jackie and JoAnna and Anna and Geeta and Dadit for being a fantastic panel today, for asking questions that they didn't even know were coming, and they did a phenomenal job of it. I want to give everybody you guys were just awesome. And for everybody who joined us today, thank you for weighing in. We need to keep going. We need that sense of urgency on this issue, and the time is right for us now to build a more equitable world through community partnerships. I am your host today, David Nelson, and it has been a joy to be at this webinar sponsored by Feeding Wisconsin. Thank you for joining us.
Thank you.